Hello, everyone. Thank you all for joining another Outcomes for Me as the Expert webinar. It's been a while since we've done these webinars. Now we're back onto a somewhat monthly cadence. So happy to have you all here. Today, we are delighted to welcome breast oncologist, Dr. Erica Meyer. Thank you for joining us from Dana-Farber Cancer Institute. Dr. Meyer is joining us to provide information and updates from the European Society for Medical Oncology Congress that happened just 10 days ago, actually, in Paris. For those of you that are not very familiar with this conference, ESMO Congress is Europe's most prestigious oncology conference and for the world's top oncologists and cancer researchers. The research studies shared at conferences like ESMO Congress often become the basis of clinical guideline updates. And this is why us at Outcomes for Me, we really want to make sure we get you the latest research and information as soon as it gets published or discussed at these conferences. For those that don't know me, my name is Maya Saeed. I am the co-founder and CEO of Outcomes for Me. Outcomes for Me wants to help and empower breast cancer patients with the tools and resources to navigate their care. So our mobile app, you can have access to free resources and information, including treatment options, clinical trials, and information to help manage your disease. The format of today's discussion will be a Q&A discussion. So we got actually quite a bit of questions ahead. So thank you all for submitting your questions. But also as a reminder, you can, and I see already some of the questions coming in, you can submit the questions live here today. We'll try to get as many as we can via the Q&A button. And also we're live on Facebook. So please submit your questions. We'll also make sure we cover them. I want to start off, so to kick it off, without further ado, Dr. Meyer, can you please give us an introduction about yourself and just, what you focus on, and then we'll jump in, to the Q&A.
Thank you so much. And thank you so much for the invitation to be here today. This is a fantastic platform and forum, and really excited to share updates. So I'm Erica Meyer. I'm a breast cancer medical oncologist at Dana-Farber in Boston. Like many of my colleagues in the breast cancer world, I split my time between taking care of patients who have breast cancer at all stages, all subtypes, and the other part of my time is mostly spent doing research. And so my research is clinical trials based. This means that I work on designing clinical trials, work on operationally opening them and running them, and then importantly, analyzing the data and presenting the data. And so that means that I work closely with breast cancer colleagues from around the world because this is a team event. We work together and also work together closely with industry partners and cooperative groups and many of the research organisms that are out there.
Fantastic. Thank you so much, Dr. Meyer. We're privileged to have you here. So just to kick it off, for you, what were the major themes in breast oncology that stood out at ESMO that you want to highlight before we get started with specific questions we got through the patients on our platform?
Well, thank you. And I'm really glad you're highlighting the ESMO meeting. For those of us in the United States, we've always thought of our kind of research calendar as having two major events. We have our ASCO meeting, which is the American Society of Clinical Oncology, so a US-based organization that has an annual meeting in June, always in Chicago, where we talk about research, not just in breast cancer, but all kinds of cancers. And then for breast cancer specifically, 6 months later, we have the San Antonio Breast Cancer Symposium, always in San Antonio, and that is breast cancer specific. These are both very big meetings. ASCO, we might have 40,000 people. San Antonio, I think might be more like 20,000, but they're very, very large meetings. And this is where we kind of plan to present the breaking news and what's hot and what's coming out. ESMO is a meeting that is on the upwards trajectory, and it's in some ways it parallels ASCO. As you said, it's Europe's preeminent oncology organization. It covers all disease types, all kinds of cancer care. And they have an annual meeting as well, always in September. And in the past few years, we are increasingly seeing some of the most important research being presented at ESMO. not only by European colleagues, but also by colleagues from around the world. And so now we are putting a new date in our travel itinerary that ESMO has really become a top level meeting, and a meeting where we're really seeing some of the most important research coming out. This year at ESMO, the meeting, I would say that one of the themes was looking at follow-up from some of the important trials, including not just sort of breaking news follow-up, but also some of the longer term follow-up, and how longer term follow-up from our trials is very important, and also brings us some of the new and important information. So we don't just want breaking news, but we want to stick with the trial and look for the sort of subsequent news developments that happen over time.
That's great. I have to say, actually, I was at ESMO this year, and it's the first time I attended. I've attended ASCO many years before, and I was pretty impressed by also the information that was on breast cancer, as you point out. So perhaps with that, so we have received questions that we've grouped along 4 different themes. One's on metastatic breast cancer treatment, then on early stage survivorship, on recurrence and risk and prevention, and early stage treatments. And again, as a reminder, if anybody has any questions, I see some that have came in, we'll ask them. Please submit it via the Q&A button in the Zoom or on Facebook in the chat. So starting with some of the questions that we had that are linked to metastatic breast cancer treatment. One of the questions we received is, what new information was shared with the trials looking at CDK4/6 inhibitors in metastatic breast cancer? Has a clear winner between the 3 been identified? And perhaps as you answer this, doctor, just remind the audience, the CDK4/6, when they're given in what setting?
Yeah, no, thank you. This is probably the most important breast cancer messaging that came out of ESMO. So remember, when we think about breast cancer, it's not all one disease. It's really 3 main categories of disease defined by the receptors on the outside of the breast cancer cell. We have hormone receptor positive breast cancer, that's HER2 negative, that's the largest category. We have HER2 positive breast cancer that can be positive for hormone receptor or negative for hormone receptor. That's the second most common category. And then the third category is when the 3 receptors that we look at, estrogen, progesterone, and HER2, are all negative. And we call that triple negative breast cancer. So when we organize our thoughts about like what are we studying and what's the tumor biology and what are our strategies, we generally try to think in the paradigms for each of those 3 subsets. Although, as we'll get to a little later, we're starting to see some blending of the subsets, which is creating a lot of exciting change in the breast cancer world. So as I mentioned, the largest group is hormone receptor positive, HER2 negative. And about 8 years ago, we began using a category of drugs called CDK4/6 inhibitor. CDK means cyclin-dependent kinase. And these are pill medicines that are taken in combination with a hormone partner, a hormone medicine partner, designed to slow and stop the growth and cycling of the cancer cell, and eventually push the cell into cell death, which is what we want, because we want to try to kill the cancer. These are not chemotherapy medicines. These are what we call targeted therapy medicines. And at this point in time, we have 3 approved agents for metastatic disease. We have palbociclib, also known as Ibrance. We have ribociclib, and we also have abemaciclib. And so all 3 agents are FDA approved. They are all approved to be used in combination with a hormone partner, which could be an aromatase inhibitor, or it could be fulvestrant. And over the past several years, there's been, I think, a really broad acceptance of how important these drugs are for breast cancer patients. And so for the majority of people who are diagnosed with metastatic hormone receptor positive breast cancer, a regimen with one of these agents and an endocrine partner is the preferred treatment. There are about 7 or 8 very large randomized trials that have looked at these 3 drugs. And very interestingly, across the board, the trials have all shown the same initial result. And what we're looking at is something called progression-free survival, which means in patients who start the hormone medicine and the CDK4/6 inhibitor, how long can it keep their cancer shrunk or stable until they need to make a change to something else? So this is, all the studies are designed to look at that as the primary outcome. And across the board, when people receive a CDK4/6 inhibitor with an endocrine partner, it basically doubles the period of time that they're able to stay on their therapy. And this was very consistent on all three drugs. The drugs, so we've all thought of them as drugs that function fairly similarly, although there are some subtle differences in side effects and monitoring and things like that. What's been new this year in 2022 is now we are seeing longer term follow-up from those randomized trials. Importantly, looking at the trials that explored these drugs as the very first step, so the very first treatment that patients received, we call it first line. And we saw data presented at ASCO, so our June meeting, just a few months ago, looking at the primary outcome of overall survival. So basically, do you live longer when you get this drug compared to not getting this drug? Now, the trials, again, were designed to look at that first endpoint, progression-free survival, but they follow patients longer to try to look at that second endpoint, overall survival. And what was shown at ASCO a few months ago was that data from two of the drugs, palbociclib and ribociclib, were both presented. In the trial where patients received ribociclib, the patients who received the ribociclib lived longer than patients who did not. That's the overall survival benefit. So we would call that a positive result. In the palbociclib trial, the data was a little difficult to interpret because the trial was not designed to collect all of that survival data. But from what was collected, it did not appear that the patients who received the palbociclib were living longer compared to those who did not. And this is despite the fact that it still gave that doubling of progression-free survival. So those are two of the CDK4/6 inhibitors. I mentioned there are three, and what we were waiting for was data from the third drug, abemaciclib. So that was presented at ESMO from a trial called Monarch 3. All the trials have these cute names. And in that trial, this was not the final result of the overall survival, but it was an interim result, suggested that patients who received the abemaciclib were living longer than those who did not. Technically, the number of months they captured was 12 months, but that is an average for the whole population. That's not for an individual person. Because of the way this trial is designed, that was not called a significant result yet. It has not matured enough for it to be called significant, but it certainly was trending in that way. The results favoring the abemaciclib were particularly notable in people who had cancer that had traveled into an organ like liver or lung, what we call visceral disease. So although technically not significant, I think people felt very favorable with these results and showed very nice activity from the abemaciclib. I think the most important message we have now is, and we've always had choice, but now we really have choice. And when we have these three drugs, we can say which is the right drug to pick for my patient. Up until about June, many people were given palbociclib as the partner agent. That's what has been most popular around the world, mostly because it is a very well-tolerated drug, and it's a drug where we are very good at managing any side effects. Since the data presentation at ASCO, there's been a little shift, and now more patients are being given ribociclib. Although for people who are on palbociclib and doing well, we want them to continue on that drug. And now we have the data supporting abemaciclib as well. Abemaciclib has slightly different toxicity. For example, it's a little more likely to cause diarrhea than the ribociclib. The ribociclib is a little more likely to cause some liver irritation. And so if there's a specific situation going on with a patient where we need to be mindful of these side effects, that can influence how we select. So there's still a lot more data to be coming out about CDK4/6 inhibitors, but these drugs are very important drugs in our breast cancer management. And this data is helping us refine our drug selection so we can try to get the best possible outcomes for our patients.
That's great, thank you. And actually, we had the question, I think you explained it very well around, the difference between progression-free survival and overall survival, and, kind of how we understand these various clinical trials, which I think you already covered. But, with all these, as a patient, what should the patient care most about when it comes to these three choices? Or kind of, would you encourage them to start the conversation with their provider around the various choices? just trying to kind of, understand what that means today for a patient.
Yeah, I mean, that's a great conversation to have with a provider. And we in the breast cancer community spend a lot of time talking about these topics amongst ourselves. I think we all agree that the most important thing is live as long as you can, survival. And so that's always been the North Star that's guiding all of the research. But looking at that as an endpoint from a research point of view is a little harder because it takes a long time to have that data mature, and it involves not just the initial treatment. So let's say someone's getting abemaciclib and they're on it for quite some time, and then if cancer gets worse, they have to switch to something else. There may be many, many switches that happen between that initial time of switching and the overall survival. And so it's measuring not just that initial step, but it's measuring many other steps beyond, what we call post-progression. And so it becomes a little complicated to interpret the data, and particularly differences between progression-free and overall survival. But I think that, I think essentially survival is what matters most, and that should be what is guiding our clinical decision-making and also guiding how we approve drugs to be used for breast cancer.
Okay, great, thank you. We'll come back to the CDK4/6 in a minute, but staying on this theme of various treatment options for metastatic breast cancer, a question we received is, will Trodelvy become a standard of care option soon? Were there any updates on the trial looking at that?
Yeah, that's a great question. And that's another exciting piece of data that we saw at ESMO. So Trodelvy is also known as sacituzumab, or sacituzumab govitecan. This is a type of medicine we call an antibody drug conjugate. So again, not a chemotherapy, not a hormone medicine, but it is a targeted or biologic type of medicine. And it's a drug that tries to target a receptor on the outside of the cancer cell using an antibody, and linked to the tail end of the antibody is a teeny tiny bit of very potent chemotherapy. And the idea is that we're using the drug. I use different analogies when I think about this, but it's like a Trojan horse, or it's a smart bomb, but it's trying to get that chemotherapy into the cancer cell very precisely to really focus on killing the cancer cell and try to minimize what we might think of as off-target toxicity causing side effects somewhere else in the body. So sacituzumab is a drug that was primarily designed to look at a receptor that we found on triple-negative breast cancer, that third kind of breast cancer, and is currently approved to treat triple-negative breast cancer. The receptor, though, can be found on other types of breast cancer. And so a study was run called TROPiCS-02, that, again, a cute name, that looked at sacituzumab.
I picked these names, but that's another conversation.
A very complicated process.
Yeah.
But anyway, the trial was designed for patients with hormone receptor positive, HER2 negative breast cancer. So again, our biggest category of breast cancer. And it took patients who had already started receiving chemotherapy for their breast cancer and had already received at least 2 different kinds of chemotherapy. And in the trial, patients are randomized to either get sacituzumab or get another type of chemotherapy that their doctor could pick for them. And there was a little list that could be selected from. The initial results from this study, which were presented earlier this year, showed that the patients who got the sacituzumab did better than the patients who received the provider choice chemotherapy. So TROPiCS-02 is a positive study and shows us that there is a role for sacituzumab in hormone receptor positive, HER2 negative breast cancer beyond the approved role in triple negative breast cancer. This was really exciting data because we've always thought of this drug as kind of locked into one subtype, but this is how we're beginning to sort of blend it into other subtypes and try to expand the benefits. The update that was presented at ESMO was, again, this idea of longer term follow-up, was the overall survival data. And that data was positive. So the patients who received the sacituzumab not only had their cancer controlled longer, that's our progression-free survival, but they lived longer than the patients who received the regular chemotherapy. So again, that's an exciting result for us, and it really confirms the role of sacituzumab in patients with hormone receptor positive breast cancer who've already had some chemotherapy. Now, I'm going to blend into what I think will be the next question from you, which is, what about the HER2 part of this? And another big development in the breast cancer world this year has been the idea of what is HER2 negative? What does that mean? And this relates to a slightly different antibody drug conjugate, a drug that's called trastuzumab deruxtecan, also known as TDXD. And this is another drug, an antibody drug conjugate that is targeting the HER2 receptor. So for that second category of breast cancer, approved for that category of breast cancer. We had data that came out this year that looked at this drug in patients with a somewhat new category called HER2 low. And what that means is that when the pathologist checks HER2 in the pathology lab, the result is not totally black and white, positive, negative, but there's actually a little spectrum and there's a score, and it can be 0, 1 plus, 2 plus, 3 plus. 3 plus is positive, 0 is negative, but the 1s and 2s are now being called HER2 low. And so a trial that was presented at our ASCO meeting called Destiny Breast 04 looked at this drug TDXD in the HER2 low compared to regular chemotherapy and showed that people did much better with this drug. Very exciting data in the breast cancer world. And again, the idea of expanding use of existing agents. So now, if we have a patient with hormone receptor positive breast cancer, if the cancer is HER2 low, if it's in that 1 plus 2 plus, and we've already had some chemotherapy before, maybe we go to TDXD. And then we could go to sacituzumab after. If the cancer is HER2 0, meaning that the TDXD is not an option, we can go to sacituzumab. So we brought in these two new tools that we can use for a subtype of breast cancer that up until basically June, we weren't using at all. So this has been a big, exciting development in the breast cancer field. And the new data from ESMO, I think, provides even more like security and interest in using sacituzumab for hormone receptor positive disease.
That's great, and that's great options for patients. Were there any advancement in triple negative breast cancer discussed?
For triple negative disease, there was not I'll call it blockbuster piece of information that came out, but the way triple negative was being looked at was, again, this idea of the HER2 low and thinking about how we can expand drugs into the HER2 low space. There's also interest in looking a little bit more with TDXD into the HER2 0. Measuring HER2 is not a totally precise science. It's something literally done with the human eye. And it's hard to know if there's any major difference between HER2 0 and HER2 1 plus. And so maybe TDXD could have a role for HER2 0 as well, and that's being looked at.
Great, thank you. Maybe a last question for the moment on metastatic, because we're getting quite a bit of questions on risk of recurrence, and also, so I'll go to that topic after. But maybe while we're still on the metastatic treatment, so one question we received is, person has been on Ibrance for 3 years, so this is palbociclib, but it's becoming less effective. And metastatic with concentration in the bones, spine, and hips, what's the best alternative medicine for me? So I think let's broaden it out a little bit around, we talked about the CDK4/6 being the recommended, at least in the context of this patient in the first line setting. If people progress, where do they go from here?
That's a very important question, because as I mentioned, using CDK4/6 inhibitors is the standard of care as our first step in treatment of metastatic hormone receptor positive disease. We hope that our patients will stay on that regimen like forever, but there are situations where the cancer can become resistant, and we will determine that there's progression. And at that point, what should we do next? What is the best next step post CDK4/6? This is an incredibly active research question right now, and there are many, many trials going on that are looking at new agents and new strategies in this space. Outside of trials, we have several choices. We had recent data from a trial called Maintain that looked at essentially switching from palbociclib to ribociclib, so continuation of the CDK4/6 inhibitor. It's a small trial, it's preliminary early data, but it did suggest that continuation of CDK and doing the switch seem to do better than just dropping the CDK altogether. But we need more data there regarding, is it the CDK4/6 inhibitor in general, or is it moving from one of them to the other? That part we don't know yet. Some cancers express a mutation called PIK3CA, PI3 kinase mutation. And if we detect that, which is something looked for in some of the standard testing for metastatic cancer, we can offer a drug called alpelisib, which is a pill medicine, one of the targeted medicines, in combination with a hormone partner to try to target that specific mutation. So there's, I'd say about 40% of people may have that in their cancer, and then we'd use the alpelisib. There's another mutation that we are interested in that I think we'll talk about in a little bit called ESR1, which is an estrogen receptor mutation. This is something that develops over time, and it is a sign of resistance to some of the hormone medicines. And so there's a lot of interest in, if we see this mutation, what's the best endocrine partner that we can be offering for someone? And a lot of that work is looking at some of the agents that are in trials. So, I would encourage that if someone progresses after CDK4/6, although one can look at clinical trials at any moment across the whole continuum of breast cancer care, that's a very ideal time to be looking around for clinical trials, because there's many, many trials in that space right now. We run many of these trials at Dana-Farber, and they're also being run at cancer centers around the world.
Thank you. And actually on this topic, and we just had a question related to this from Leanne, diagnosed in June 2020, has been 18 months, no evidence of disease with Kisqali, then progressed after Afinitor and Xeloda. So, now I think looking at the second line treatment. Her question is, she's ER positive, HER2 negative, but the FISH score is 2+. And therefore, given now everything we've discussed so far, the question is, should I discuss TDXD with my doctor? How do we think about all these options, right? Because there's the, looking at the PIK3CA mutation, as you mentioned, there's cycling through multiple CDK4/6, there's the clinical trials. How does one, and which is great because that means there's more and more options in the metastatic setting, but how does a patient, start the conversation with their doctors in this context?
Yeah, no, you're absolutely right. In breast cancer, we have like an embarrassment of riches in a way, because we have so many choices. I always like to use the analogy of we have a toolbox, and that the toolbox has a lot of tools in it already, and we keep putting new tools in the toolbox, and that's great. But the challenge is, how do we best sequence the tools and use them most effectively? I think that, something I always come back to when I'm working with patients on these decisions is thinking about what are the goals of what we're doing. Obviously the big goal is live as long as you can with metastatic cancer. That's our North Star. But also, and equally important, is quality of life, and thinking about how the treatments affect the body, what the experience of receiving a treatment is like, and what does someone have a pre-existing condition or sensitivity that would make a medicine either easier or more difficult to receive. One thing with this particular case is Leanne's had hormone medicines, and then she's also had Xeloda, which is a chemotherapy medicine. And sometimes when people make a transition from hormone medicine into the chemotherapy category, they may feel like they have to stay in the chemotherapy category and just keep getting different chemotherapies. But that's not always the case, and we can go back and forth. So even though someone may have received chemotherapy, it doesn't mean they can't go back and try another hormone option as another choice. Now, TDXD, it is something that we look at post Xeloda. So, definitely talking about that with the doctor makes sense, but it's also important to talk about, do I have to do something like that right now, or can I try another hormone choice? I will say endocrine or hormone-based options tend to be among our better tolerated choices. They don't necessarily involve coming into the infusion unit. There's a little more flexibility versus getting a medicine that's intravenous, and TDXD is intravenous. So one would have to come into the clinic and have infusion. So, for some people, that's a very important distinction. So I think thinking through all the sort of risks and benefits on both sides is part of how we make those decisions.
Great. I think we'll probably come back to some metastatic, but I do want to start covering some of the earlier stages and recurrence risk, and starting with some of the questions we got live, actually. And feel free to submit questions via the Q&A button on Zoom or live on Facebook. So we had a couple of questions linked to Ki-67 as a test, and maybe on explaining what that is. When is it important? the first 5 years, or after that, does HRT raise Ki-67 levels? So maybe just broader, and some people may not know what Ki-67 mean.
Yeah, so Ki-67 is a test that's done by the pathologists in the pathology lab. So just like I mentioned, estrogen receptor, progesterone receptor, and HER2, those are staining tests that are done in the pathology lab. Ki-67 is another staining test that's done in pathology labs. And it's basically a test of proliferation. Is the cancer growing more rapidly or have a little bit more turnover, or is it more kind of sleepy and slow growing? And you might think, well, that's really important information to know. Although we do get some of that through some of the other features that we learn from the pathologist, like the tumor grade. Ki-67 is a little bit of a tricky marker, and part of it is that it's a little hard to run that test in a pathology lab. There have been these studies done where they ask 7 different pathologists to score Ki-67. They'll give them the slides and they say, look at these slides independently, give me your score. And the scores are all over the map. It's not a very precise and consistent test. There are international guidelines that were recently published to try to have all pathologists do it the same way and try to be more consistent. But cancer centers argue a lot about whether it's important because it's so, it can be so inaccurate. Ki-67 has become more in the news recently because we did have a drug approval about a year and a half ago for one of the CDK4/6 inhibitors, abemaciclib, that was built, or the approval included Ki-67 as part of the approval language. This was a controversial move from the FDA, partially because the trial data for that approval wasn't restricted to Ki-67, like the drug helped people who had high and low, and it wasn't limited by Ki-67, but also people pushed back and said, this is not an accurate test. It's not routinely done in all pathology labs. And so I'll tell you at Dana-Farber, we do not do Ki-67 because we just find it's too inaccurate, and we do not use it in our treatment decision-making. So, I would describe it as an extra piece of information. It's not something that all treatment decisions and all thoughts about the cancer hinge on, but sometimes we might use it when we're thinking about adding the abemaciclib, as I alluded to.
Great, thank you. We had a few questions submitted ahead of time, but also live from Mila here on DCIS. So, I just want to broaden out to ask, what's new with DCIS? The 2 questions we had were linked to hormone, tamoxifen, and, a comment hearing that European doctors are reducing dosage for 5 years. So, let's broaden it up a little bit and kind of, what's new for DCIS and how is it being treated?
Yeah, no, thank you. So DCIS is ductal carcinoma in situ. What this means is it means that there's cells in the breast that have changed, they've mutated, and they have a cancer-like appearance under the microscope, but they've not penetrated or invaded through the breast duct. They are still basically on the outside of the body. We think of it like a pre-cancer situation, something that if left alone could turn into an invasive cancer. But if we find it, then we try to treat it and prevent invasive cancer from happening. The biggest risks with DCIS are that it could turn into invasive cancer or it could come back after treatment. In and of itself, it does not have the capacity to spread in the body. It cannot become metastatic cancer. So for that reason, we really think about it in a very different category than invasive breast cancer. I will tell you that there's actually a move afoot to try to remove it from under the breast cancer umbrella because it's really not a breast cancer, it's a pre-cancer situation. That being said, the treatment for DCIS does in some ways mirror what we do for invasive cancer. For example, people need surgery, people might need radiation treatment, and if the DCIS has hormone receptors on it, there could be a role to use some of the same hormone medicines to help prevent the DCIS from coming back in the breast. The 2 main categories of drugs that we can use for DCIS are tamoxifen or the aromatase inhibitors, AI medicines. And these are both medicines we use all the time for invasive breast cancer. The duration of therapy for DCIS is 5 years. We do use longer durations for invasive breast cancer, but we do not use longer durations for DCIS. Most recently, there has been a study that came out that was not really designed for DCIS. It was designed more for the prevention setting, but looked at using a lower dose of tamoxifen than what we typically give for DCIS. The trial enrolled people with a whole spectrum of precancer findings, including DCIS, but also including just the atypical cells. And in the trial, people received a lower dose of tamoxifen versus regular. And what they showed was that the outcome in terms of prevention seemed the same for both arms, but the people who took the lower dose had less risk of some of the rare but more serious side effects of tamoxifen, like risk of blood clots. And so based on that data, we've started offering people lower dose tamoxifen. We offer 10 milligrams instead of 20 milligrams when treating DCIS, but we would still continue it for the 5-year course. But increasingly also there's, as part of this move to get it out from under the breast cancer umbrella, sometimes people being treated for DCIS may actually go to a DCIS clinic that's run by surgical oncology. And so they being seen by medical oncology may in the future not be part of the management for DCIS.
Okay, thank you. I want to stay on the topic of endocrine therapy, and we have actually a couple of questions that came live, and also they're all in the same category, questions that came submitted, which is all linked to the duration of hormone therapy, 5 versus 7 years, AI versus, also, I mean, we could cover separately the side effects from AIs. But first, the question more on timing, how long should patients stay, and is that changing in terms of guidelines, any new data there?
Yeah, this has been an active area of evolution over the past several years. So once upon a time, we gave 5 years of endocrine therapy to everybody. And then we began to see data from the trials that were looking at longer durations. The first trials that came out looked at 5 years versus 10 years. And those trials used tamoxifen as the main medicine, mostly because the trials started so long ago that we weren't really using aromatase inhibitors as much. Sorry, excuse me. It takes a long time to do these trials. It takes decades. And so it reflects a little bit how treatment was when the trial was started. But the trials did show that patients who did 10 years of tamoxifen seemed to have an improved outcome, so less cancer recurrence compared to people who did 5 years. However, the longer someone stays on tamoxifen, the greater the risk of some of those rare toxicities. I alluded to blood clots as an example of that. And so there was a little bit more of that seen in the longer duration treatment. We then began to see a variety of other trials coming out that were looking at a whole variety of different durations, 5 years versus 7 years, 7 years versus 10 years, and kind of having a mix and match of being on tamoxifen or aromatase inhibitor. At this point in time, the most relevant recent trial that has been presented is a trial actually from my colleagues in Austria. There's a wonderful breast cancer research group in Austria that does a lot of this important work. And that trial enrolled patients with stage 2 and 3 hormone receptor positive breast cancer. And patients were randomized to get a 7-year course of endocrine therapy versus a 10-year course of endocrine therapy, and showed essentially there was not a difference between the two, that 7 years, people who did 7 years did just as well as 10 years. Now, the trial included many people who had negative lymph nodes, which generally we would think of as a somewhat lower risk population. And so I think that the decision to target 7 years is very appropriate for people who really match the folks who are on that trial. And so we really try to tailor duration based on the stage of the cancer, like size and lymph nodes, the sense of risk from the cancer and the stage of the cancer, and also how's someone doing on their endocrine therapy? How's it going for them? Generally, for the majority of patients with stage 1 breast cancer, and so those are small node negative cancers, we're still recommending a 5-year course, because once you extend beyond 5 years, the risk benefit ratio of those kind of long-term toxicities that begin to build with time begins to outweigh any extra benefit. However, in someone with stage 1 cancer who's tolerating it well and really motivated to stay on it longer, maybe we'll go out to 7 years. For most of my stage 2 patients, we will initiate with a target for at least 7 years of treatment. And if someone has stage 3 disease, meaning they may have multiple lymph nodes involved, I might still go towards 10 years. But again, it's all tailored based on how someone's doing. And if someone gets to 5 years and says, man, I've been working really hard taking this therapy and it's not been easy, and but I made it to 5 years and I feel like I can't go any further, then we say, great, congratulations, you got a huge amount of work done, and we move on from there. So it's a partnership together, and we make these decisions together.
That's great. And actually related to that, also a question live here is what happens after 10 years? In other words, actually the question is specifically what characteristics are most likely to present with the recurrence, and do we know actually?
Well, the risk of recurrence from breast cancer is related to the tumor biology and the tumor stage. And for hormone receptor positive breast cancer, it's really built around stage, meaning the size and lymph node status. We know that these cancers do carry a risk of recurrence that extends beyond 5 years and may extend beyond 10 years. And this is really the motivating reason why we've extended the duration of adjuvant endocrine therapy from 5 years to 7 to 10 years. We do know that when patients stop their endocrine therapy, there's something called the carryover effect, which means that for several years afterwards, there is still a benefit to endocrine therapy that's building. So even though someone stops it, they're still getting ongoing protection from it. But beyond 10 years, we don't really have data that's looked at going longer than 10 years on therapy. So we generally are telling people to complete their therapy when they get to 10 years.
Okay. Are there any new drugs? So this is a question we received ahead of time. Is there a new drug for me, a stage 3 breast cancer survivor, to keep a recurrence to possibly stage 4 from happening? I'm hormone positive, HER2 negative.
Yeah, that's a great question. And there's a couple drugs to talk about. First of all, I mentioned the drug abemaciclib, one of our CDK4/6 inhibitors. That's a drug that was studied in a trial called Monarch-E. Again, that cute name, Monarch. And in that trial, patients with higher risk breast cancer that was defined by having lymph nodes involved or having that Ki-67 or having a higher grade were randomized to get their ongoing endocrine therapy with 2 years of the abemaciclib pill versus the endocrine therapy alone. And the results of the study showed that the abemaciclib appeared to improve how people did. There was about a 30% reduction in the chance that the cancer would come back. And that was a significant finding. And based on that data, that led to FDA approval of adjuvant abemaciclib. We're coming on 2 years now since that drug was approved. So for our patients who would have met criteria for that study, and stage 3 breast cancer generally did, then we would be offering adjuvant abemaciclib in those situations. That's something that's generally started, I would say, within about a year of someone's surgical treatment for breast cancer. So it happens a little earlier on in the course. And it's, as I mentioned, concurrent with endocrine therapy. You take both at the same time. Now, an area of research interest right now is, well, what about someone who's 5 years out? Is there a way to determine what we do next? There's a lot of interest in if there's certain testing that can be done. For example, is there a blood test that will tell us what's the residual risk? And there's a tremendous amount of research work in this space. There is the capability to send a tube of blood and to detect something called circulating tumor DNA. That if the ctDNA is found, may indicate more risk than if someone doesn't have it found. It's a really exciting scientific platform. The challenge right now, though, is we only want to be doing testing that's going to help us apply a tool to help people work better, to help people do better. And so sending testing to learn more about risk, but not having a way to appropriately address the risk is what is the space we're in right now with the research. And so there's great efforts going on right now to design trials for people who are several years out from their initial diagnosis and treatment. the idea in the trials is to send a test like a ctDNA test, and then based on the result, try to modify the ongoing treatment to try to overcome any risk or try to address anything found in the blood test. So that's something that I would describe as a research platform right now, and something that goes on in research studies. Definitely a study to be looking out for, but not something that I'm recommending for people to be doing outside of a trial. And then to that point, one of the drug categories of interest right now is something called oral SERDs. These are not chemotherapy. They're actually endocrine therapy, and it's a new way to target the estrogen receptor. These are pill medicines, and they are under very active study right now for metastatic hormone receptor positive breast cancer. What we are learning from the trials is that cancers that develop the ESR1 resistance mutation that I alluded to before may be the best candidates for these oral SERDs, and they may work better than other types of hormone medicines that we have. And so there's many active trials going on for metastatic cancer, and we are just in the process of opening up trials in the adjuvant setting. So for people who do not have metastatic breast cancer, but to see if these drugs will work better than the existing hormone medicines. The drug that's probably closest to potential FDA approval is a drug called elacestrant that was studied in a trial called the Emerald trial. Again, it's a cute name. And so we are awaiting to see if that drug will get FDA approval, which would be kind of a brand new endocrine choice for patients. So we're very hopeful that we're going to see this new tool added to the toolbox.
That's great. You talked about, I do want to follow up on something you mentioned, and we had a specific question that I think you answered already, but just, to cover it around the ctDNA, circular DNA testing. We had a question, is there a standard recommendation for the new Signatera ctDNA? Should it be a routine part of blood work done at checkup appointments? So I think you covered it, but just to be clear on kind of, this part.
Yeah, so Signatera is one of the commercial ctDNA assays that is available. So even though I mentioned that we do this in a research setting, technically it could be done outside of research. It's not something I'm recommending to my patients though, because as I mentioned, if we send a test like that, we do not yet have the appropriate tools to manage how we both interpret and work with the results. And we only want to be learning things about the cancer and learning things for our patients that will be able to help us have the patient do better, have a better outcome. And if we send a Signatera test, we don't yet have a way to use that data to help somebody do better in the long run. So, it's a very exciting technology, but for me personally, I need to see it be clinically helpful for people, like to help people have a better outcome from their breast cancer before it's something that I'd want to be encouraging people to do.
Great. I know we have 5 minutes or so left. I'm going to try to cover 2 sets of questions and then we'll wrap it up. So going back to, the first set is around the early stage treatment, or how we treat early stage breast cancer. So first is around, a couple of questions. I'm going to group them together, one that came live from Facebook and one that was submitted. The question is, one of the questions, I understand long-term data was presented for high-risk hormone-positive breast cancer that looked at dose-dense chemotherapy versus standard interval chemotherapy. Could you explain what we learned and if it will change the way medical oncologists treat early-stage hormone-positive patients? In addition to that, I just want to cover, more broadly, oncotype testing, and also this or may not be related, but we got it via Facebook. Question, do you use the breast cancer index test to make endocrine duration decisions? So I don't know if they're all part of the same themes or not, but it would be great to cover them.
That's great. So let's start dose dense. So dose dense chemo means that chemotherapy is given more frequently, like closer together than standard. So up until about 2003 or 2004, we would give people chemotherapy, and we're talking about adjuvant chemotherapy, so what people get like after surgery, every 3 weeks. And based on mathematical modeling and some sort of predictive models from colleagues of ours at Memorial Sloan Kettering, the thought was if you give the chemotherapy every 2 weeks instead of every 3 weeks, the cancer has not had enough time to recover. It's just started growing, so you can hit it again sooner. So a trial was done in the United States looking at every 3 weeks versus every 2 weeks. And results from that trial demonstrated that the every 2 weeks, people who got every 2 weeks did better, less cancer recurrence. So based on that trial, which was again presented in the early 2000s, dose-dense chemo became the standard of care when we're giving adjuvant chemotherapy. And this is specifically referring to a regimen that we call AC plus T that has 3 chemotherapy medicines in it. It doesn't refer to a regimen that many people get called TC, which has 2 medicines in it. We did see some long-term follow-up data at ESMO that looked at an Italian study that was basically asking the same question and had the same result, that dose dense was better than the every 3 week. And they were presenting a very long-term follow-up, like 15-year follow-up from the study, again, confirming the benefit of dose density. So we've now seen this in many different ways, and it provides great reassurance to us that this was the right move to change to dose dense. So it doesn't affect our practice because we made that change over a decade ago, but it confirms what we're already doing. Regarding Oncotype, so Oncotype is what we call genomic test. It's a test done on tumor tissue, usually the tissue captured at the time of surgery in patients with hormone receptor positive, HER2 negative breast cancer. And it is analyzed looking for a kind of a signature, a score. And there's been a lot of work learning how to interpret that score, specifically thinking about, does the score indicate that the cancer is sensitive or not sensitive to chemotherapy? Once upon a time, people with breast cancer would have surgery and lots of people would get chemotherapy. And those decisions were just made on size and nodes without the understanding of tumor biology. Oncotype taps into a better understanding of tumor biology, and specifically that honestly, the majority of hormone receptor positive breast cancer is not sensitive to chemotherapy. And we don't want to give people chemotherapy if it's not going to help them. So Oncotype really helps us refine who are good candidates for chemotherapy and who should not receive it. For the majority of patients who are postmenopausal, which we might think of as older than 50, Oncotype can be very, very helpful in helping prevent the use of chemotherapy. The data in our younger patients, our premenopausal patients, has been a little trickier to understand, partially because when someone is premenopausal and they get chemotherapy, it's possible the chemotherapy may put them into menopause. It may actually turn off the ovaries earlier than it would happen naturally. And in some ways, that's a good thing because we know turning off the ovaries and dropping the estrogen levels is a great way to treat hormone receptor positive breast cancer. But it's been a little hard to sort out from the trials when we see benefits in people who get chemotherapy. Is it specifically from the chemotherapy, or is it because their ovaries have been shut down by chemotherapy? We have ways to shut down ovaries that don't involve chemotherapy. You don't need to use that as an ovary shutoff tool. So it requires a little more interpretation in our younger patients. And finally, breast cancer index. So that's a similar test as Oncotype. It's looking at a signature from a breast tumor biopsy or surgical sample. The company that does breast cancer index has been marketing the test as a tool to help establish long-term risks of recurrence. Is somebody at risk of recurrence beyond 5 years? It's a little controversial because we can kind of know that information already just based on the initial features of the cancer, such as the hormone receptor, the grade, the nodes, the size, all of those things we learn at the time of surgery. And so many of us would say that a breast cancer index test is not really necessary to make treatment decisions, but it is being marketed a lot right now. So that one may come across an advertisement or information from the company that's promoting it. So if someone's interested, it's worthwhile to talk to your doctor about it.
Great. 2 very quick questions. It may not be quick answers, but I know we're going to have time. So, and we won't cover everything we received. One, I just want to make sure we cover it. Are there any updates to share for early stage triple negative breast cancer, which patients are now being offered Keytruda immunotherapy?
Sorry, let me just
make
make sure we have time for that.
Yes, and then the last, where I want to conclude, because we had, we had questions on long-term management, but also, a patient about to start treatment, haven't started yet, wondering what, if diet, exercise, vitamins, can get them better. Same questions, but now to prevent recurrence. Even a question, just about drinking Diet Coke 6 to 8 cans a day, is that contributing to breast cancer? But perhaps, and I know we don't have much time, but if we can cover the immunotherapy in triple negative, anything new there, and then maybe just concluding, and we probably will do another separate webinar on just overall lifestyle, but your message to the patients would be helpful.
Yeah, so regarding immunotherapy means medicines that stimulate our immune system to target and fight cancer, the same way our immune system fights infections. And these medicines have revolutionized cancer care, particularly for some kinds of cancer like melanoma, kidney cancer, lung cancer. For breast cancer, the use of these medicines has been a little bit more limited to the triple negative breast cancer, negative for the 3 receptors. And we do use one of these medicines called pembrolizumab, also known as Keytruda. It's an antibody medicine in patients with triple negative breast cancer who are receiving chemotherapy before surgery. Currently, for patients who are presenting with a stage 2 or 3 triple negative breast cancer, rather than jump right to surgery, the preference is we give our chemotherapy and we give the pembrolizumab beforehand to try to maximally shrink the cancer and get the patient ready for surgery. And that's a maneuver which not only helps facilitate surgery, but also helps to prevent the cancer from coming back. The pembrolizumab is also used in some patients with metastatic triple negative breast cancer. And there's a lot of research to try to expand use of the drug outside of just triple negative disease. Regarding survivorship care, and yeah, it's not fair to only have like negative time to talk about it, but there are very standard guidelines for how we follow breast cancer survivors that are established by our national organization, ASCO, and are quite the same throughout the world, consistent throughout the world. But we generally want people to follow what I would call a healthy lifestyle, but it's not something that has a lot of specifics around it. So we want people to get regular exercise. That's something that honestly I strongly encourage. It doesn't mean training for a marathon, but I'm trying to get a mix of cardio and weight exercise is helpful for breast cancer. It's helpful for health in general. There is no specific breast cancer diet. There has been studies looking at this, and the main signal to come out of that research is we don't want people gaining weight. I mean, nobody wants to gain weight, but it does seem to be specifically not helpful for breast cancer if people are gaining weight after their diagnosis. We want people to eat a healthy diet that allows them to maintain their weight or lose weight if they think they need to lose weight. The research that's looked into alcohol suggests that people should limit their use of alcohol to, on average, half a glass a night, which might be, let's say, a few glasses of wine a week. People don't need to, be incredibly restrictive about that, but, just not to have too much. And there are no special vitamins or supplements that have been shown to be helpful for breast cancer. We do tell people to take vitamin D because sometimes the breast cancer medicines can threaten bone health, and vitamin D is good for bone health. But there's no other supplement that has been shown to be particularly helpful or effective. And then the diet, someone had asked a question about drinking 8 cans of Diet Coke a day. And I would just say, I don't think it's good to drink 8 cans of Diet Coke a day, not just for breast cancer, but just in general. Trying to find a healthier alternative like flavored seltzer or something like that. You won't gain weight from it, but it's probably not good for you in general. So I hope that answers all the questions.
Thank you. We covered essentially a lot of, so first of all, Dr. Meyer, I know we went a couple of minutes over time. Thank you so much for taking the time with us today. And thank you for all that has joined us. If you have any follow-up questions, if we didn't get to answer a question, please, you can submit your questions on the app, the Outcomes For Me app. You can download it and ask any question via the Ask button. Our team of nurse practitioners will be able to cover it and answer it. We'll also make this recording available on the app, and we'll be communicating following with messages about how to get access to this and what topics you'd like to have a follow-up. So thank you all again. Thank you, Dr. Meyer, and have a great day. Thank you very much.
Take care. Bye-bye.
Thank you. Bye.